Thank you, Shan. Archana, thank you very much, everyone. I am going to take the next 8 minutes of your time to talk about the use of botulinum toxin for abdominal wall hernia. I don't have anything to disclose. And this is the scenario that I'm going to talk about, patients with large hernias with different amounts of loss of domain. And abdominal wall hernias are an off-label indication for the use of botulinum toxin according to the FDA. There are several ways to measure what botulinum toxin is able to provide to the abdominal wall. One is by performing electromyography to these patients, and the machine, the information that provides us is the amplitude of the muscle, and they give us with these numbers in microvolts, and if we translate these numbers into the intensity of a given color, like the red, we will see that the muscle in the left side is how a normal muscle will look like, and the one in the right side is how it will look 1 month after injection of the botulinum toxin. Another way to measure what botulinum toxin provides to the abdominal wall is by measuring the thickness and the length of the injected muscles. In the abdominal wall, particularly useful is CT scan in Valsalva maneuver. So we see, and this has been published even in systematic reviews of the literature, how the muscles get thinner and longer, and this provides a decrease in the horizontal size of the hernia. Recently, these years, I published the changes of botulinum toxin in intra-abdominal volumes and also in herniated volumes. And we saw that because the muscles get thinner and longer, the intra-abdominal volume becomes increased and the herniated volume becomes decreased. This is the same patient before and 1 month after injection of the botulinum toxin, both CT scans in Valsalva maneuver. And you will see how the CT scan in the right side looks like an easier hernia to repair compared to the one before injection of the botulinum toxin. So when calculating different loss of domain scores like the Savart ratio and the Tanaka score, we see that there is a significant decrease in these loss of domain scores after injection of the botulinum toxin. Another way to measure the effects of the toxin is in the operating room by noting how easy it becomes to mobilize the muscles from lateral to medial, even in large hernias and in patients with some degree of obesity. So by doing this, hopefully we will be able to downstage the procedure that is required for muscle closure, decrease the tension and the chances of fascial tearing during the muscle closure, decrease the chances of leaving a breach, decreasing the chances of muscle dehiscence in the early postoperative period, and also decrease pain in the early postoperative period, and decrease the time that is required to complete the preoperative progressive pneumoperitoneum. Right now, we are halfway in the pyramid of the evidence-based surgery to demonstrate these outcomes. So in my practice, the indications for the use of botulinum toxin are the presence of loss of domain and large defects in the horizontal size. So how much loss of domain? In this study that I published this year, the cutoff point that was useful is 10 for both the Savart score and the Tanaka score. If I injected patients with less than 10 of these scores, the change was non-significant, but above this score of 10, the degree of change was significantly reduced. What about the size of the horizontal size of the hernia? We really don't know. All the patients that I injected with botulinum toxin had a horizontal size of 10 centimeters or more, and the benefit was more or less the same regardless of the initial size of the hernia. So there is a possibility that even smaller sizes of hernia will be benefited from the injection of the botulinum toxin. I'm going to talk to you about some useful pharmacological considerations. There is a botulinum toxin type B, which is 50 times weaker than type A, and it is used only in patients with cervical dystonia. Really, what we use for the abdominal wall and for all other uses in the human body is botulinum toxin type A, and there are 12 different companies producing it all over the world. Here you see the first curve is placebo. The next one below it is a low dose of botulinum toxin. The next one below is a higher dose, and the one in the lower level is the highest dose. And you can see how the higher the dose, the deeper the inhibition in the muscle tone, but the length of action is the same regardless of the dose. And it's a total of 3 months, but the maximum is between 2 weeks and 2 months. It has been calculated that the LD50 dose in a 70-kilogram human is around 3,000 Botox units. There is an European consensus advising to administer a maximum of 600 Botox units per session, and the FDA, for the uses that it is allowed, advises to use a maximum dose of 400 units per session. In the abdominal wall, you will see descriptions of having it administered in different places and planes, but there is a trend towards administering it in the external oblique and the internal oblique muscles, which is the majority of the bulk of the lateral abdominal wall. Previously, there were some guidance to follow external landmarks to perform the injection, but in patients with lateral hernias or the presence of stomas or bowel between the skin and the abdominal wall, it might be not so appropriate. So it is better to inject it with ultrasound guidance. We can see the needle, we can see the muscle, and we can see the fluid as it is entering in the muscle we want to inject. In terms of diffusion, it depends on the brand, the dose that it is used, and the volume that it is used for dilution. We know in cosmetic surgery that if we use a very few injection points, there is a chance we might miss some of the muscle. So it is actually advised in cosmetic surgery to perform as many injection points as required to make sure that we are going to tackle the entire muscle. And if we say, I will overcome this by injecting a lot of volume, the problem is that botulinum toxin is able to diffuse through fascia, and it can go superficially to the fat, where it will be a waste because it doesn't have any action there. So the way I do it is that 4 weeks before the surgery, but it can be any time between 2 weeks and 2.5 months, and prep and inject lidocaine. I inject 200 to 300 units of Botox divided in one half in one side and the other half in the other side. And then to one vial of 100 units, I add 4 cc's of sterile saline. I mix it, and then with this opener that Allergan provides to the surgeons who use a lot of Botox, I open it up, and with a 20 cc syringe that I have preloaded with 12 cc's of saline, I draw the 4 cc's with the toxin. I mix it in this 20 cc syringe, and I have 16 cc's with 6.25 units per cc. And I am going to inject with a 22 gauge spinal needle connected to that 20 cc syringe, 1 to 1.5 cc's into the external oblique and 1 to 1.5 cc's into the internal oblique at each one of these 8 zones. So small volumes, several injection points. And hopefully, after doing this, I can provide these changes in terms of function, structure, and the experience that we have in the operating room. So by doing this, we can provide abdominal wall reconstruction to these patients with large hernias, with these degrees of loss of domain, with stability of the results, and with the change in quality of life that we can have. So in conclusions, botulinum toxin is an evolving tool in abdominal wall reconstruction. It reduces the horizontal size of the hernia, and also it reduces the amount of loss of domain. We are in the process of defining the best methods for its use, and we are also in the process of refining the demonstration of its clinical outcomes. Thank you very much.